Joey, Rayce. Welcome to the podcast. Super excited to chat with you guys today. For people who aren't familiar with you and all the incredible work you're doing, especially around athletic low back pain, would you mind filling me in a little bit about who you are, all the amazing stuff you do as clinicians, as entrepreneurs, as educators?
Fine, I'll take it. What's up, guys? I'm Joey Scambia. I'm located in New Jersey. Just actually opened up my own practice inside of a large gym, Renaissance PT and Performance. So it's kind of that sister company, if you will, to Rehab Renaissance, which is our online educational platform and in-person educational platform, mainly geared towards other clinicians, strength coaches, chiros, ATs, that whole spectrum of healthcare providers. And our goal is to continue kind of raising both the floor and the ceiling in the rehab space. So yeah, that's kind of our whole mission, both in person with my practice and then with Rehab Renaissance.
And then I'm Rayce Houser, Performance PT out here in Portland at Roke, Performance Therapy. Work with anyone ranging from middle school age athletes all the way up to high performing, professional baseball athletes. And yeah, one of the co-founders of Rehab Renaissance, and like Joey mentioned, just education platform to really try to help raise both the floor and ceiling for performance rehab.
Absolutely. And one of the things that I feel like the two of you are becoming quite well known for, in my opinion, is raising the ceiling and the floor in this space of athletic low back pain or spondy fractures, or overall just providing more of a framework to manage the lower back in the athletic population. And, I don't think people are shocked when I say the stat that like 97% of Americans have lower back pain. And usually when they hear that stat, at least for me, I think about someone who's maybe in their 70s or 80s, has all these degenerative changes going on. And we just think, oh yeah, that makes sense. But it's like, we've seen 16, 17, 18-year-olds who come into the clinic that say, oh yeah, I've had back pain for a year. I've had back pain for 2 years. The more I do, the worse it gets. I've tried resting, it doesn't help. And I found a lot of clinicians get very confused when trying to treat the lower back because there's so many anatomical structures there. There's a lot of pain referrals there, and they're just not overly sure where to go a lot of the time. So I guess just to start us off here, where does the clinician start in relation to managing the athlete with lower back pain? I'm assuming it starts with some kind of evaluation or assessment, but from like a framework standpoint, where do you guys teach and start with managing and assessing the lower back in the athletic population?
I'll kick this off because I'll just give a brief background on how this kind of course all came to be. So this really just started as a quick, like 45-minute presentation that I was supposed to give to all the staff during residency. So it gave me that opportunity to kind of dive into the literature and to see what was actually out there in terms of return to sport testing, exercise progressions, recurrence rates, all that stuff. And just across the board with return to sport, with, optimal interventions, recurrence rates, like there was terrible literature out there, pretty much non-existent for the return to sport and for the return to sport stuff, and pretty poor literature across the board for recurrence rates. We did a pretty good job literature-wise from what we know getting people back, but once they're actually back, their recurrence rates were awful. So this was a great opportunity for me to kind of use this literature to put this presentation together. Got really good feedback from the staff, showed it to Rayce, started chatting about the material from the presentation, and then we decided, hey, should we just beef this up to something a little bit bigger? That led to us presenting it to Rayce's former PT program, Pacific, out in Oregon. Then we got good feedback there, reconvened again. Hey, we should probably beef this up a little bit more. And then that kind of turned into the whole course. And really this whole thing stemmed from my experience as an athlete. I had a terrible rehab experience with a spondy in college. It was the typical, go to the local clinic at home in the off season, table exercises, all the narratives of, neutral spine, don't bend, don't rotate, don't twist. Meanwhile, I have to get back to playing Division I baseball. So all those kind of narratives and that experience really shaped my passion for wanting to build out this course. And we wanted to make it principle based to where we can apply it to literally any diagnosis. Doesn't necessarily have to be the low back, but a lot of the foundational topics and talking points are obviously built around the low back because that's kind of the whole outcome with the course. So I'll have Rayce kind of finish that, but just wanted to give the whole background of kind of how this all came to be.
Yeah, I don't know how it was for both your guys' PT programs, but I know my PT program really talked a ton about non-specific low back pain. and it seemed to generally revolve around the ages between like 18 to 65 is at least the population that we kind of talked about it with. And I feel like when it comes to low back pain athletes, we pretty much apply that non-specific low back pain framework to the athletic low back pain. And I feel like with that non-specific approach, we're like, oh, it doesn't really matter what tissue's involved. Like we can kind of give them some sort of graded exposure. Whereas with the athletic low back pain, one, we're thinking it's actually can be a very, very specific cause of low back pain. Like we probably have a decent idea of what the structure actually is. And two, it's also very, very mechanical based as well. And so when you start looking at, I would just like your general differential diagnosis list, like you're probably looking to choose between like your spondy or some sort of like stress reaction in the lumbar spine, some sort of disc injury, and or some sort of like muscle strain. And it seems like research suggests that probably spondy might be the more prevalent one. I know there's been research to suggest that for potentially like a full actual like or some form of stress fracture, whether complete or incomplete, it can be up to 50% of a chance that someone comes in to the clinic has back pain. There's a 50% chance that they may have potentially incomplete or complete fracture. And there's potentially a 60% chance that they have just some sort of stress reaction kind of along the sort of continuum of bone marrow edema there. I've seen studies say as low as like 25, 30%. So it kind of depends on the literature that you look at. For disc, you're looking at somewhere between 7 to 27%. And I haven't seen any specific literature on strains or like the number of essentially like prevalence or incidence rates for muscle strains. And I know I definitely have a population bias in terms of seeing, one, in Maryland, a ton of lacrosse players. Two, out here, I see a ton of baseball players. And so I feel like because of that, I would say 95% of the low back pain cases I see, I'm definitely thinking much more spondy based. And I can count probably on one hand the number of patients who I've had who have had disc issues in like the 14 to 18 kind of age range there.
Yeah, absolutely. And you brought up the combination of baseball and lacrosse and some of those rotation-based sports possibly being a little bit more biased towards the spondy. For people interested in kind of more that mechanical model for a second, why do you feel like that those sports are so common to have these lower back type injuries pop up, right? Something about that extension, side bend, and rotation combo where it's like on one hand, maybe all of that should be coming from their hips. Maybe we shouldn't expect lumbar type injuries from that. But on the other hand, that's what's breaking, not bending here. So why do you feel like, at least from maybe the mechanic side for a second, these sports have such a high incidence of something like a spondy occurring?
I think a lot of it comes down to like specificity of what their actual sport requires. So I think the top four from one of the articles was like football, baseball, wrestling, and gymnastics. I would definitely bucket lacrosse in there as well. Like we can draw very much similarities across like all of those sports, right? They all require you having to assume some sort of end range posture, more likely than not at a very high load or high velocity, and oftentimes happening with a ton of force, whether it's somebody's own body weight, like a gymnast hitting the floor, or like making contact with somebody, obviously in football. So I feel like all of those have such similar traits and characteristics from like a range of motion and sporting demand standpoint, where it makes sense that kind of those clusters of sports are typically higher in terms of spondy prevalence, because you're getting into a ton of repetitive extension rotation with a lot of those positions. And just eventually over time, it leads to that kind of the micro trauma in the pars, and eventually that leads to that stress reaction, which unfortunately a lot of times becomes that stress fracture. So I think it's definitely comes down to a lot of the sport demands and similarities amongst those, I think, 5 sports that I mentioned.
And the other thing I would add to that too is one, L4, L5 have like the highest rates of spondies. And so I'm just thinking like compressive loads and like superimposed body weight, like we're gonna have the highest mechanical loads there, which probably puts them at a higher risk for some sort of bone stress related injury there. Two, I'm thinking just like facet orientation, lumbar spine, like we're not getting a ton of rotation. So we're probably getting compression across those joints fairly early in that rotation, whereas we can probably disperse that stress a little bit more as we kind of move up the trunk there a little bit. And then third thing, just when we start to look at the differences in terms of who ends up getting the bone stress injuries, typically we think more of our adolescent population. And just given what we know kind of about their morphological structure in terms of their bony anatomy, like typically their bones are still going to grow up through 19, 20 years old, at least in the lumbar spine. And because of that, some of the cortical thickness in the bone is still developing. And I think that's probably one of the other reasons that we're seeing some of those spondies is because that bone's still developing, and just the strength of that bone and the full like mineralization is still not like quite there at that age range yet.
Right, right. That's another key point as well, is I think a lot of the times, I'm probably guilty of this myself, we look at that 15, 16, 17, 18-year-old athlete, and they have the schedule of someone maybe 10 years older than them from a sports standpoint, but we forget physically and physiologically, their body's not at that level yet, right? They're still growing, they're still maturing, there's still CNS adaptations that have to occur in addition to what's occurring on the skeletal side. And it's like we forget that, right? We forget that they're still just a kid because they've been doing their sport seriously for the past 10 years and change, right? Like they were born with a freaking baseball bat in their hand sometimes, I feel like. And it's like, I get it, ball is life, but at the same time, we have to find a way to maybe meet these kids where they're at a little bit more. And, obviously that was more geared towards the mechanical side, but on the flip side, you also brought up the non-specific low back pain as well, Rayce. And I think this is an area that a lot of clinicians get so frustrated with, because a lot of them market this philosophy of root cause, right? Well, I'm going to get to the root cause of your injury, and I'm going to have you walk out of here after an hour and tell you the one thing that caused this and the one thing that it is from a diagnostic standpoint. But when it comes to the lower back, sometimes it's not one thing, hence the term non-specific. It's not specifically one thing. It can be a multitude of things, a combination of things. And clinicians, for better or for worse, get very frustrated by that. I know I have been as well in the past, where it's like, I just want it to be this one thing. How do you go about, you mentioned frameworks in the past. Where do you all kind of gear people towards on the non-specific side when it's like, hey, look, my patient wants answers. How do I educate them, and how do I develop a plan for the foreseeable future? Maybe that's 12 visits or whatever, when I don't even know what one thing, if there is one thing, is causing this.
I think we could go two separate routes. I'll go the specific back pain route first. Typically, if I go through my exam and nothing's pointing me to a specific red flag like bony pathology, then my mind goes more to that non-specific low back pain case, where I'm typically not really pro-imaging. And I'll say the first 4 to 6 weeks, if we're continuing to hammer this and there's really no improvement in symptoms, then I might refer out to get another set of eyes on it. But as we go to the other hand, where I think it's much more specific, specifically like that bone stress injury, I'm very pro-imaging fairly early on, where I'm almost going to refer out at the same time or give it like a week or two. So like still treat them in the clinic, but say, hey, within the next week or so, like I want you to get to an ortho and get this imaged, just because the imaging or the literature shows that the earlier we can diagnose these, the better the outcomes are. The earlier the diagnosis, we can get like 70 to 90% back to sport if we can tackle these like right away. So that's where Rayce is, when he was discussing before, this is something that's actually specific back pain. If we can get on top of these quicker, it's going to be much easier getting these athletes back to the field from a prognostic standpoint. So I know we still have the conversation a lot, especially on social media, like, oh, we don't need imaging, push back imaging until like last resort. But in a case like this, where we could potentially be dealing with a true bone stress injury, like the earlier that we can get them an x-ray or a potential MRI, the better it's going to be for that particular athlete. So that's where the evaluative skills and taking a really good subjective comes into play. Like, are we making the actual delineation between non-specific, or is it something more specific, more that bone stress injury part of the continuum? So that's where I think we can kind of delineate those, because one, we don't necessarily need imaging right away. The second, I'm a much bigger proponent of pushing for imaging pretty soon.
And then I'll kind of piggyback off that with the non-specific. I typically think, not like older people, but like as we start to age, I start to like think of that being more as kind of like, just with kind of all the age-related changes we see in the spine, I don't necessarily care at that point, as long as we've ruled out our red flags, like what the tissue is that fall, just because likely there are going to be quite a few changes, whether it's stenosis, whether you have a mild disc bulge. And at the end of the day, like when we get to that point there, that's not really going to drive what we're doing from a treatment standpoint. It's more what mechanically what's irritating their back, and then from that way, is there some sort of entry point where we can get them into movement, exercise, and then from there kind of gradually expose them back. As it relates to athletes, I think at times we've almost taken like the I 100% advocate for the biopsychosocial model. But I think at times we've gone too far down that rabbit hole where we forget anything that's like pathoanatomical related. And because of that, I think when it comes to like lumbar bone stress injuries, they will commonly get misdiagnosed, especially if individuals are unaware of like bone stress injuries happening in the lumbar spine. And then two, because they are misdiagnosed, then they're mismanaged. And then typically that just facilitates a much, much longer rehab cycle for them, a rehab plan for them.
Yeah, no, I think you're spot on with that. And I think it's one of those things when there's an absence of a pattern, sometimes that is the pattern, right? Like, oh, like I'm going into this eval and I think it's going to be discogenic, and then none of the discogenic signs are there. And then I think, oh, well, it's going to be soft tissue related, and then none of the soft tissue signs are there. Oh, well, maybe I think it's SI, which we could probably have a whole discussion on the freaking SI joint and if it actually moves. But none of the SI signs are there. And it's like, if none of these things in my little deck are aligning, then it's like I have to think about the thing that's not, commonly thought about. And that would be, as we were mentioning, that fracture type presentation or stress fracture, stress reaction in the pars of the lumbar spine that way. And it's like, again, making sure you note these things down. And I think a lot of the times, like if I'm like lost on something, I literally, and this is probably old school, but I'll literally take a piece of paper and just write it all out in front of me just so I can visualize it in front of me and just see where everything is. And hey, we've got this, we don't have this, we don't have this. It just makes it a lot easier for me to see it all right in front of me, I think, than it is to try and like conceptualize it in your mind in the moment. So I think drawing it out certainly helps. And I think, as you mentioned as well, both of you, nailing this down from a diagnostic standpoint and not being afraid to tap out to the imaging early on, if it is something that you're highly concerned about, can really expedite this problem. Now more than ever, we're all under a growing amount of pressure to produce results and produce results fast and get people back to sport fast. And if not, then it's like, okay, our scholarships missed, our NIL opportunities missed. How much is that costing not just the system, but also the athlete themselves and their potential opportunities that they've worked so hard to gain? And it's like you almost have to be pro imaging for some of these things, even though I know there's literature against imaging for certain lumbar pathologies. And I think you brought that up as well, Joey. But it's like, if we don't get people these answers, it becomes such a more difficult thing to manage. And it's like, depending on how far it slips forward, how do you reduce that conservatively? Like, obviously, you can manage it with a lot of exercise and different things, but on the mechanical side, I've seen people attempt to like reduce a spondy with, anterior to posterior belt glides. I've seen different brace type things, and I haven't seen anything that's led me to believe that it can be done consistently and reliably yet. But maybe you guys have seen something different.
I mean, I'll use my own personal anecdote. When I had my spondy, like I was placed in a brace 23 hours a day, like pretty much only took it off to like shower and get dressed. So I was in that for like 3 months. Go to another orthopedist back home because I was going to school in Boston at the time. So I was back in New York, get home, went to him. First thing he says is like, why are you wearing that? I would never put any of my patients in a brace. So like, number one, like we have the two completely separate opinions of two orthopedic doctors. And then two, that just leads to a whole psychological piece of my plan of care. Like, did I just really waste like 3+ months of wearing this for no good reason? So that really messed with my head, like during that case, like a ton. And then it seemed like there's still to this day, like no consensus on should people brace, should they not, how long should they wear it, not only during the day, but like how many months, how many weeks, and like how should you actually wean off of it. I think we don't have any like conclusive good insight there from a literature perspective. So I feel like that kind of muddies things as well, just because we don't have a true gauge of, how to manage these, at least in the acute phase. So like we're big proponents of, delineating relative versus absolute rest. Like, because I was pretty much absolutely resting. Like I wasn't really doing much. So by the time I actually got back to the field, I wasn't run through any test battery. I wasn't running through any like outcome measure psychological battery. I was just like, okay, you're good to go. We've hit the time block. But like in reality, from a athletic preparation standpoint, like I was nowhere near ready. So that's why we are big proponents of relative rest, where we're trying to do as much as possible, keep as many different buckets or qualities filled, or prevent the decay of any of them as much as possible, while we're still respecting the constraints of what's going on at the back. So I think those are the two big things, like getting them to actually perform relative rest where they're still doing things, and not having them just actively rest. I feel like, or sorry, absolutely rest. I feel like that's the big key differentiator there.
And then kind of the approach that we'll talk about in the course is using an optimal loading approach, and just understanding with like bone pathologies that ideally we want to keep things pretty much pain-free during the exercise, following the exercise, as well as like that next day. And if we're having some sort of pain during, afterwards, or that following day, typically it means there was either some sort of chemical or mechanical irritation of that bone. And doesn't mean that the injury is then reoccur. It just means that we need to make some sort of slight modification, whether it's position, whether it's external load, whether it's velocity, any sort of exercise parameter that we can adjust to then allow them to continue to do X, Y, and Z, or certain exercises pain-free. That way we can continue to allow that bone to heal. I know there's no consensus. Well, I'll take that back. Right now, it seems like more of the consensus is probably towards we take more, or we put more stock in patient function versus imaging. Like if we were to do serial imaging, and if they still have bone marrow edema but no symptoms, we put more stock in how they're doing functionally. There's some newer literature coming out of, at least in the Australia area, in the cricket population, where they're starting to put more stock in the imaging. So even if individuals are still pain-free, high-functioning, high performance, and there's still signs of bone marrow edema, they're still holding them out until that kind of clears up. I know there's also another study from Australia as well, where they're looking at pretty much they followed a handful of cricket players kind of over the course of the season. And, there are a handful of players who end up developing bone marrow edema but never had symptoms. But if you did have bone marrow edema, there was a higher chance that you then went to be symptomatic versus those who didn't have bone marrow edema.
Yeah, that's interesting that now there's almost a shift back towards the imaging. And my initial thought on that, and I'd love to hear more from the two of you on this, I've seen a number of patients who are 17, 18, 19, and they've been told that their stress fracture, it's non-healing. It is what it is. It's never going to get any better, right? And, some of them have had it for 2 years, some of them 3 years, and they're like, yeah, I went to an ortho, and, the imaging at week 4 after it happened looks identical to, year 2 after it happened. And they're like, that's the best it's ever going to get. And it's like, one, is the body truly incapable of healing some of these injuries, or is it our imaging modalities are not specific enough to pick up the changes that are occurring? And if it is something that truly cannot heal from a bony standpoint, then why is it not healing, and what can we do to ensure that these bony injuries, whether it's a spondy or whatever, because again, you mentioned before, a lot of these principles apply to other regions in the body. How can we make sure that we don't set an athlete up for a course where they have a non-healing stress fracture, as opposed to, the correct course, or where they should be?
Yeah, I think that goes back to, when we actually get the image and then the result, we could have different types of spondies. So we can have what's called like an active spondy. We could have a cold spondy, or a mix. So active would be like you get the image back. There is a ton of T2 signal. We know there's edema in the area. We know there's healing taking place. Versus a cold, there would be no T2. Like there's just the fracture line. That's more of a chronic injury. So that goes back to your point. Like that's likely no chance of bony union. Like it's already done healing, and that's kind of the best we're going to get, unfortunately. And it seems like the ones that end up that way are like multi-level spondy, so like an L3 through an L5, or like a bilateral lesion where it's on both sides of the vertebral body, versus like a unilateral side or a unilateral lesion, much more likely to get pretty close to 100% in terms of bony union, but definitely the multi-level or bilateral much tougher. And then we could have a mixed lesion, meaning one side can be like weighted on the T2 and one side could have no edema. So that one side's actively healing where that other side is chronic and done. And then also from an x-ray perspective, if it's caught on an x-ray, odds are it's going to be that cold one. Like there's probably no more healing taking place. And another thing about x-rays is that spondies are missed on like 70% of them, which is pretty high. So if we're still suspecting that spondy, then as a clinician, like I'm going to try to make the push, hey, maybe we should probably get an additional image like an MRI as like the next step. So that's kind of how you can delineate the types of spondies and then which spondies might have a better chance of union versus ones that are pretty unlikely for union. But the good thing is that like with some of the literature, I know Rayce was saying like the cricket population, like they're starting to get back into or place more stock in the imaging. But I know one of the studies that we cite in our course is that even those athletes that don't have union or bony union, like 70 to 90% are getting to high level sport. So that goes back to like the patient presentation, like taking precedence over waiting for a perfect radiograph. So I feel like it's still leaning towards the patient preference, but it seems like, more recently, a little bit more stock is being placed on the image itself. So just kind of something of note there.
And I have a couple things. Hopefully I can remember both. First one, my suspicion is that some of the reasons why that they're progressing to this non-union is one, I think they're probably just mismanaged and misdiagnosed in the first place. And so, hey, it's like, hey, it's okay. Like we can work through, 3 out of 10 in pain, and they just keep working through that. And the pain continues to linger. Bone continues to get pissed off and never fully heals. So with the second point there, I know there was one study that looked at if you have a bilateral pars fracture, there's a 75% chance that you then go on to develop a spondylolisthesis, which I thought was pretty high. And, if we're having like a non-united deficit there or defect, my one thought is like similar to ACL where we have those individuals who are those copers. I still kind of view the spine in a similar sense where, if we have some sort of non-united defect, some sort of spondylolisthesis, like the passive stability of that spine is going to be reduced, but that doesn't mean that we can't then use more active means via muscular strategies to then counteract that. And I kind of view that similar to like the copers who they don't have their ACL but can still get back to high level function. And so that's kind of my general thoughts there as to why, one, they chemically have those non-united defects there, and then two, some of the ways that they're able to then kind of cope and kind of work around still having like that cold spondy.
You also brought up the concept of pain again. And again, I feel like everyone is familiar with lower back pain to a certain extent that way, but there's that debate that exists in our space of how much you chase the pain, right? On one hand, I feel like some PTs have become more pain neuroscientists than what traditional PT might have intended. And on the other hand, I've seen the other end of the spectrum where people ignore the pain entirely. And I personally think the best answer tends to be somewhere in the middle. But would love to hear your thoughts on the concept of like chasing pain and managing pain in this population. And also, is there anything that consistently pops up as good for handling the pain? Because obviously a lot of these people want to feel better and they want to feel better quick, even if they have to refrain from engaging in sport for some time. They just don't want it to freaking hurt most of the time. So it's like, is that an exercise mediated approach? Is it a manual approach? If so, what is that manual, or what modality, if any, do you reach for? I mean, I think pulsed ultrasound is dead in 2025, but maybe that's the thing here. I don't know.
To me, personally, a lot of it comes down to education because I was just working down at IMG. So my population was literally the ideal candidate for someone who's going to develop a spondy. So I think just educating them, I would have this conversation literally like 5 to 10 times a week, like familiar symptoms versus like exertional or effort discomfort. I feel like I would always have to make that distinction because the kids were so poor at truly describing like, is this the pain that brings you to physical therapy or is this something different? So like with a spondy, I want to get that exact answer. Like, yes, this is the pain that brings me to physical therapy, like the familiar or chief complaint versus like, I use the bicep curl for an example. Like, does this feel like you just did bicep curls to failure and you're getting that like burning fatigue type feeling? I've had plenty of times where like, oh yeah, it feels just like that. And I'm like, okay, great. Like that's what we want to chase. We don't want to chase, the familiar thing that's bringing you to PT. So I feel like, especially with the kids that I was working with at that age, had trouble deciphering, true pain versus actually putting in effort and that effort resulting in the discomfort that we're kind of looking for to get the adaptation. So I don't know if you have anything to add on that, Rayce, but I feel like for me, education was far and away the biggest one there with navigating pain.
Yeah, I think big thing is like when we start to differentiate between bone pathology versus soft tissue, like we'll talk about this in our course too, is like just using a very simple stoplight analogy or stoplight approach. So like for those bone pathologies, those bone stress injuries, like really the only green light that we have is at 0 to 10. So ideally we want everything to be pain-free. Versus I feel like for a lot of our soft tissue conditions, we can kind of work into that 3 to 5 out of 10, kind of depending on like their symptom irritability. So we'll kind of make that distinction there. In terms of stuff that I feel like has worked, some people have responded well. I know I've had some patients back in Maryland who end up being placed in a brace. We're still coming to see me, and they feel like the back brace actually helped alleviate symptoms. And in those situations, like I'm okay with that. Like, hey, if we can reduce pain, I'm okay with that. Some people, it seems like they don't get much of a benefit from it. Personal experience, I haven't had much, and maybe who knows, my manual skills might just suck, but I have not had a ton of success with doing a bunch of like manual work, especially if I'm thinking like more of your typical like joint mobilizations. If I do go more towards the manual soft tissue route, I know there's not great evidence for cupping. I'll use cupping more as just like a soft tissue technique because my hands get cranky. But I do feel like the spondies have responded like decently well to that. It kind of loosens things up or makes them feel a bit better. And when we get back into doing more of our active base interventions, it seems like they can tolerate a little bit more. Other things that I think have worked too is just working on general hip mobility, whether it's just doing a little bit of light stretching for hip hip flexors, adductors, getting some hip mobility for like the hip external rotators there. And it seems like that just kind of from like a global perspective, just kind of decreases like the muscle tonicity, just kind of generally in that hip, pelvis, lumbar spine region. And those have been some things that I think have worked relatively well. Other things too is I think from a sensory motor standpoint, like can we get them to find certain positions? Can we get them to feel certain tissues? And then from there, can we have them, because we're getting some just gentle muscle contractions, can that also kind of decrease some of the tonicity kind of surrounding like the lumbar spine, especially those paraspinals and like QL?
Yeah, someone just had a really good post on LinkedIn about this recently, about tone and how much some of these other things matter. And it's like, if the lumbar spine is hypertonic and painful and all of these other things, then like, you're not going to magically put the off switch on those muscles. They're still going to work during exercises like RDLs, single leg RDL, and so on that way. Like they're still going to play a role, but like, could you maybe shift the tone? So maybe it's less hypertonic, or maybe, from a strategy standpoint, like if we just chase, hip strength and just motor control standpoint, go all in on the hip. And now the attractor state for the hip becomes an inch wide and a mile deep, as opposed to a mile wide and an inch deep. Then it's like, hey, maybe we've just done something that is very advantageous from a change standpoint, by literally just going all in on the hip and kind of like letting the lower back cool off. And I feel like a lot of the times, depending on how someone comes in, like day one, I might not even do anything from an exercise standpoint for their lower back. Like we might not even get to anything core related on that day, because if it's that hot and flared up, to the point you made before about finding an entry point, it's like sometimes that entry point is literally the things that support it that aren't that one thing, right? Like it's not the lumbar spine, but I feel like the hip plays such a close link to the lumbar spine that, yeah, I have no issue going in there. And I feel like one of you brought it up earlier, but even looking above sometimes, right? Like I can't tell you how many times I've seen athletes with lower back pain that typically gets worse when they kind of shift into that hyperextension position. Maybe they've got a ton of lordosis, that sort of thing, especially gymnasts. And then you look at their T-spine and they have like no thoracic extension. And it's like, well, again, we can work to stabilize the lumbar spine, but maybe we should also increase thoracic extension. And, in the short term, could we find a way to improve T-spine extension while the lumbar cools off? Like I'll make that transaction every time. So I think it's a great point about just understanding the role that you can play in this space. And again, going back to the tone comment again, like I think a lot of the times conversations around tone and muscle activation go out of context, for lack of a better way to put it. And it's like, I think a lot of these principles that you learn in school that maybe you think don't matter now because you're working with athletes, they still play more of a role than I think we give them credit for.
I want to hit on the tone piece because I've had several spondies where the lumbar paraspinals were just like freaking rods. I did a couple needles on one kid. I kid you not, when I pulled the needles out, it was like a zigzag. Like that's how much tone there was. So like that's where my mind goes to like these flexion based like positional breathing, like three-way child's pose, or like hold on to a TRX, get into a deep squat and just breathe. Like let those paraspinals just lengthen and relax. Like also get them out of that sympathetic state that they're probably in because they're in pain, they're guarding, they're scared, right? They're fearful of moving. So like getting them into that parasympathetic state where we can put some length through those paraspinals, I feel like has been helpful just to just get them relaxed and just bring their central nervous system down a little bit. Cause yeah, I've had some super jacked up paraspinals where it's like you palpate it and it's like a rod after these like spondy injuries. So much so that it literally bends the needle.
Like you're hitting a concrete wall, for lack of a better way to put it. Earlier, you also mentioned about there being a lack of consensus in relation to the return to sport framework in this population as well. And I think that's another thing that people are constantly looking for, right? Like, we mentioned the pain component, which obviously if we can resolve pain, that might help on our return to sport progression. You mentioned the radiographs earlier and how, healing there is ideal, but I think clinical improvement could also maybe hold just as much merit, depending on the case, possibly more merit like we discussed. But outside of that, I think now more than ever, people love numbers. They love testing and assessments, and they want to know, where do we go from a lumbar spine injury? Do we look at the hip alone? Do we look at core muscle strength? If so, what do we do to look at core muscle strength, and how do we quantify it? So I'd love to hear your thoughts in relation to kind of return to sport for this population, because I think if I had to guess, it probably looks quite different than ACL return to sport battery might.
I mean, in the literature, non-existent. Like when I was doing my lit review for this presentation in residency, like all the systematic reviews just used similar jargon, like uncertain, more studies needed, no optimal interventions, like return to sport literature lacking. So like there was nothing. So that's why I built the battery as part of the presentation to kind of fill that void. Where it's like a phase-based approach. It's not like a single day in time. I know we discussed this many times throughout the course that, return to sport is a process. It's not a single day in time, which is why we develop a tier-based system to make sure like from the start of the injury all the way to clearance that they're checking every phase of the battery along the way to actually make sure they're ready. And what's interesting is that the most literature that's available is the least specific interventions and the most remediary interventions. But as we get more towards return to sport, where we're doing a lot of trunk plyometrics and ballistics and change of direction, where it's much more specific to what an athlete's going to have to do, the amount of literature surrounding that is pretty much non-existent whatsoever. So, we're obviously using what evidence we have and informing our decision. So instead of being evidence-based, because there's literally no evidence, we're just being evidence-informed here and, creating a battery that makes sense based on sporting demands, based on the velocities and ground reaction forces that are needed to handle those demands. And that's kind of how we structured the battery, going from isometric to isotonic to ballistic and metabolic to kind of close it out.
I think the hard thing is we don't have any, at least as we get more towards like the middle stage, like that isotonic testing phase, as well as the ballistic and metabolic, like we don't have a ton of information or normative values. Like for the partial trunk curl up, we have some normative values for GHD, like lumbar extension. We have some normative values for that. We have normative values for our 5-10-5 pro agility test. But in terms of like our most specific, which I would consider is probably like our ballistic cluster with our different med ball tosses that we do. Essentially, can they handle flexion extension under high velocity, high force, rotation with lateral flexion and flexion extension. So kind of covering all the different planes of motion that they might experience in sport. And, whether you're using like a pocket radar or some sort of digital device to measure output, like we don't have any normative values. Hey, like if you're doing, let's say, 4-pound medicine ball and you're doing a shot, like rotational shot put, you should be able to throw the ball at 30 miles an hour. Like we just don't have any of that normative data. And I know Ben Ashworth, he has like a rotational overcoming like payoff iso that he does. And he was suggesting about 20% of body weight. That's kind of like a rough metric for oblique strength there. And so that's one thing that we've kind of played around with there as we've continued to go through not only like testing individuals ourselves, but also as we've gone through the courses and stuff and had great conversations. Like we're starting to almost like refine some of the things that we do from a test battery standpoint. And so like our one overcoming pale off ISO, some of the literature that I think is unpublished technically from Ben Ashworth, but he does like a standing position, 20% of body weight. I know Jason Tiori and the guys at Dungeons Dynamometers will do a different position with like a half kneeling and a lower leg block. And you kind of compare the two there and you just have so much more output with that half kneeling variation, because you can kind of press that inside leg up against like a immovable object there and just create counter force to help stabilize there and really allow you to kind of get better isolation to the trunk output versus I would say the vast majority of people, even when they widen their stance super far for that standing version, like their feet just start to spin and they just can't generate enough torque to counteract that force they're creating from the obliques there. And so like, even as we go through our system and framework continues to adapt and evolve just based off, conversations that we've had with other individuals.
Absolutely. And you also mentioned the concept of trunk plyometrics, which I'm sure someone is thinking, well, I've seen studies that show like, hey, the reaction forces of different muscular tissues like quads and hamstrings during different plyo, or even sprinting for that matter, and even certain joints, like what's going on at the ankle and knee. But I think a lot of people probably aren't familiar with that in relation to the lumbar spine. What's a general kind of rule of thumb as far as low to high load or force through the lumbar spine from like a plyometric and athletic activity standpoint, if you will?
You break things out into like quadrants where like we've kind of plug plyometrics and where they belong in like a continuum. So we break it out into like the amount of coupling that's taking place. So if something's short coupled happening at the trunk, it's going through quick ranges of motion. So not a ton of overall joint excursion. Sorry, not quick range of motion. We'll call it like ground contact forces, for example. But the spine's not really going through a ton of motion versus long coupled. The spine's going through a lot more motion. And then we have impulse kind of going up and down. So obviously higher impulse, lower impulse. So if we had like a shorter coupled, low impulse, that would just be like, mini scoops, the pogos of the low back, like we'll call them, versus something, where it's high impulse, long coupled, like those would be like full range of motion, continuous windmill slams, where now we're at a high intent and the spine's going through a ton more motion. So that's like a simple way to kind of delineate intensity and the amount of overall range of motion that the spine has to go through. So we kind of break that down from, the low intensity, low range of motion to high intensity, a lot of range of motion, which is going to be needed for sport.
And then as it relates to bone stress injuries and bone loading, typically what we see is, typically if we think of someone falling from a 16-inch box, and if they go through, let's say they stop their momentum at 0.3 seconds versus someone stops their momentum at 0.5 seconds, like the person who stops at 0.5 seconds will have lower ground reaction forces just based off the impulse and the force time component there. But what ends up happening from a bone loading standpoint is even though the ground reaction forces were lower with the 0.5, we actually have more bone loading because now we're in deeper ranges of motion. We have longer moment arms. The muscles then have to contract harder. So the force that they're pulling on the bone with is now greater. And so that's why we're seeing greater bone load, even though the ground reaction forces are lower. So we end up applying like a similar approach to the spine, where we'll probably start with more short coupled based, getting, quicker coupling and uncoupling of that med ball, not going through as much joint excursion there, and then progressing more to our long coupled, just kind of based off a bone loading protocol or like a bone loading framework using plyometrics with a bone loading framework.
Yeah, I love that distinguishment between muscle forces and ground reaction forces as well, because I think a lot of the times people confuse the two. And they're unfortunately not the same. It's not that simple. But I realize we could probably talk about this all day long, because there's dozens of other talking points and questions flowing through my mind right now. And just to throw a bunch out there, it's like, from a loading standpoint, like where and when do you place the load in what positions during exercise, right? When do you go front load versus back load? If we're going to work overhead into pressing, when do we work overhead, and what is compensation free that we're willing to live with, and what level of compensation are we willing to accept from the lumbar spine? And similar concept with extend in rotation and deflection that way, right? Like, do they need to have a certain control level of hip disassociation? Is there something that we should be looking for at the hip in relation to what the pelvis and lumbar spine is doing? Like, there's so many questions circulating through my head right now. And I think all of that comes back to the point of it's really important, the work that you guys are doing to try and raise the floor and to try and elevate the standard in this space, because again, we've seen this go unchecked for a long time, and athletes have unfortunately been done a disservice as a result. And, we just cannot accept that and cannot settle for that. We have to do better. And that's where, again, the work of guys like you in the space is elevating the standard for the rest of us, right? Like, we need people like you in order to continue to push forward. So really big shout out to you guys for all the good stuff that you're doing in the space that way, through the course and beyond that way. Is there anything we missed as we were chatting, or anything else you guys wanted to bring up today?
You want to hit on the load placement, Rayce? We have specifically like a lab devoted to that and how it influences the spine. So you can kick that off.
Yeah, I'll touch on this real quick. So load placement, we'll kind of take this from like a PRI-esque kind of lens. I think some of that stuff is kind of useful there. But typically from a loading standpoint, we're typically thinking more of like an anterior load. And I kind of relate it to like our typical PNF patterns with the scap, where typically we get that bilateral protraction, get more of like a flexion-based or neutral-based position. So typically that's kind of a better entry point for individuals there versus that back rack position. We're getting that bilateral retraction there, more of that extension-based position. Chest kind of presses forward. Center of mass, which will refer more to that kind of the chest region there, pushes forward there, and just typically puts them in a more extension-based position there, which typically not the best entry point usually for a lot of times for that extension-based low back pain, especially those spondies there. If we're getting more into our unilateral loading variations, if we're thinking more of let's go contralateral load, it's going to induce like a slight hip IR or rotation towards that lead leg there, and more from like a yielding or braking standpoint, it's going to help with some of those kinematics, versus if we're thinking way on the ipsilateral side, we're going to get a little bit more of a pushing away or outside of that lead leg there. And so it might help with more of that propulsion-based kind of kinematics there. And then if we get into more of our, front rack-based positions that are more unilateral load, like if I go unilateral front rack on that right-hand side, it's going to induce like a little bit of rotation towards that right side, because that protraction, essentially, like if I reach forward, like that's going to be more of that kind of protraction there. So like that front rack on that right can be like a sneaky way to kind of get pseudo rotation in to that right. Same thing if we go with the left there. So like those are some easy ways that we can kind of conceptualize load placement, how they influence trunk positioning, and then how we can kind of bias certain motions based off load positioning.
Yeah, I'm big fan of that. Big fan of that. That was really well breaking down, Rayce. For people who want to find out more about y'all online, where can they find you at? Instagram, TikTok, YouTube, Facebook, MySpace, Uvu, Skype. I mean, what are the kids using these days?
Our IGs.
IG.
That's the best way. Rehab Renaissance, Rayce, Roke, Joey Scambia, DPT. Probably the best three. We're definitely most active on Rehab Renaissance. Pretty much all of our posts will have a collab of our, personal accounts on there.
Yeah, no, that's awesome. We'll link to all of that in the description below. That way, if you didn't quite catch it, you can just click there and see everything the guys at Rehab Renaissance are up to. Guys, this was awesome. Really appreciate your time and everything you're doing.
Thanks for having us, Dan.